Good morning, everyone. My name is Erin Croywa, and on behalf of the Automotive Safety Program this morning, we welcome you to today's webinar. We will be pleased to hear today from Michelle Macy, Dr. Michelle Macy. So we are here today to talk about, after the crash, why size-appropriate seats matter. And we are so thrilled that Dr. Macy has carved out time for us to be able to offer this CEU opportunity to you. So without further ado, we would like to introduce the topic of today, after the crash, why size-appropriate child seats matter. And so today we're going to talk about the importance of size-appropriate child restraints and talk through real-world examples of injured children from the scene of the crash to the emergency department to hospital discharge. And so we're going to talk about common crash-related injuries throughout the first decade of life and the ways that different child passenger restraint system modalities help to mitigate the injuries that we're going to look at. And so Dr. Macy, just a little bit about her, and she'll be available for video so that we can have her available today. We are so looking forward to her. Dr. Macy is a pediatric emergency physician at Ann and Robert H. Lurie Children's Hospital of Chicago. She's been providing emergency care to children who've been injured in crashes since 2005. She's an associate professor in the Department of Pediatrics at the Northwestern University Feinberg School of Medicine. Her research focuses on understanding parent decision-making around child passenger safety and using novel behavioral interventions to increase the number of children who are using the size-appropriate restraint on every trip. She's the principal investigator on an NIH-funded R01 study to evaluate ED-based intervention to promote correct and consistent restraint use among parents who are not following current recommendations for child passenger safety. Welcome, Dr. Macy.
Thank you so much, Erin, and thank you everybody for being here. I'm disappointed that we weren't able to do this in person, but thrilled that they were able to get creative and make this Zoom CEU opportunity a reality for you. So thank you for that wonderful introduction, Erin. I don't have any conflicts of interest, but do have grant funding from NICHD, as Erin mentioned. And I also want to just share with everybody that the details in these case examples are drawn from my real experience, but I have made modifications to the presentation of the information to protect the confidentiality of my patients. We're going to link child age to size and those weight limits that we have on seats. We're going to review several common injury patterns for child passengers who aren't using optimal restraints. And then I'm hoping to share some new perspectives of the impact of the work that you all do. So my journey as a child passenger safety researcher came at the end of my fellowship training as I was entering into my first role as an attending physician. And 3 weeks after I started as an attending, I had my third child, Oliver, who's shown there and is now a feisty 10-year-old still using a booster seat. But on the end of my maternity leave, the radio came on one morning and NPR was featuring the states that were holding out on passing booster seat legislation. And it really got under my skin to hear these legislators talking about it being a parent's right to choose what they were doing with their child's safety. Because I've not met a family of an injured child who really felt like when the law wasn't up to what is best practice, that they had made an informed choice. And so what I did as I got back to work was took a look using a national survey mechanism that we had at the C.S. Mott Children's Hospital and University of Michigan. And my oldest was starting kindergarten as we had 3 kids all using restraints, and we solved the problem of a sedan that was too tight to accommodate that by getting another car. But it really struck me as I started to think about this, that there's a lot that families are navigating when they're trying to do the right thing with their kids when they're traveling. The information can be confusing, and there's just a number of social factors and environmental factors that are contributing to the choices that they made. So we did a survey nationally of what families were doing when they were carpooling with children and whether or not that was related to their booster seat use. And we found that among families who were typically booster seat users, if they were doing carpooling, they were less likely to have their own child use a booster seat, and they were also unlikely to ask another family to use a booster seat. And this was one piece of a line of inquiry that I've gone along looking at how parents are making these choices and what we can do to really support those decisions as they're trying to do the best for their kids. These are lines that are probably familiar to many of you on the call, particularly when we're thinking about motor vehicle crash. You know that it remains a leading cause of death for children. And unfortunately, it ends up being a cause of death that it seems like people have gotten very comfortable with, and the issues around firearm safety and cancer are often given a bigger spotlight than motor vehicle crashes. But I think that we've got some recent uptick in motor vehicle crash among children that we need to be mindful of, and it validates the importance of the work that everybody has done over the last several years and decades to see this tremendous decline in crash-related fatalities for kids. When we take a closer look at crash fatalities for the younger children and those that you're working with in a child passenger safety technician capacity, we've seen the greatest improvements over the last 40 years for the kids who are under 1 year of age in the top blue line. But there's some concerning uptick there, and I think it's something that we need to not be complacent about and feel like our work is done. We've flattened out in our improvements for kids who are in the 1 to 3 and 4 to 8-year-old ranges. So again, I think we can continue to drive these numbers down towards 0 deaths through the important work that you all do. And it's just a call to continue for that improvement. And the reason for these improvements is because of a lot of changes in terms of the available equipment, the available vehicles, anti-lock brake systems, airbags. All of those things are really helping drive those numbers down. But even when we think that we've made important improvements in the fatality rates, I think it's vitally important for us to remember that for every 1 child who's dying from an injury, there are about 25 who are hospitalized, 925 who are treated in ERs, and many more who are cared for in doctors' offices. So that fatality set of numbers is really just the tip of the iceberg. And when we look at how much an average hospital stay costs for children who are in crashes, we can see that being restrained, even being suboptimally restrained, does make a difference in terms of the costs associated with those hospital stays. And we also know that we've got the best protection right now from injuries for our youngest patients, the less than 1-year-olds. And we see this steady increase as children age up and age out of more protective restraints. And with folks at the CDC looking at data from crashes, that optimal restraint behavior, which I think they take a more liberal definition than many of you would take on what is optimal. We see that as children are getting older, they're not using car seats. And then for the 8 and 10-year-olds, they're not even using car seats or seat belts. And that is where we see those increases in fatalities and injuries. The American Academy of Pediatrics is really a leader in terms of helping us all understand what we want to be conveying to folks as far as best recommendations for child passenger safety. And in 2002, the message was really simple and easy to understand. Kids should go rear facing until they're 1 year and 20 pounds, forward facing until they're 4 years and 40 pounds, and a booster seat until they're 8 years and 80 pounds. And you see these recommendations echoed in a lot of the child passenger safety laws that we see throughout the country. In 2011, the American Academy updated those recommendations. And in 2018, they reaffirmed their position on rear-facing car seat use until at least 2 years of age. But with the more nuanced information that they wanted to convey about the importance of having kids continue to use 5-point harnesses, rear-facing seats, and booster seats as long as possible, it became a lot harder to be messaging that to families. And so now families are receiving messages about rear facing until at least 2. And I think over time that's gotten a lot of traction. But then using a forward facing restraint with 5-point harness for as long as possible until they've outgrown height and weight limits, and then a booster seat up until they're 57 inches in height or 4'9". As a pediatrician, I think this is something that we think about a lot, and that progression from being a newborn to a toddler to a school-age child to a teen and then an adult. And with that physical development, we also see some really important changes in body proportions. And you can see here the infant is going to have about 1/4 of their total body size in their head, and then those proportions kind of even out. And these physical changes in muscle strength, in bone strength, and also in kind of behavioral development are important for our thinking about why a rear-facing car seat, a 5-point harness forward-facing car seat, and a booster seat are going to be helpful over the first decade of life. Another thing that in pediatrics we spend a lot of time thinking about, and those of you who have children have probably spent time in a pediatrician's office looking at these growth curves, are sort of where is a child tracking along relative to their peers in terms of their height and weight. And as we go through the talk, I'm going to use these growth curves that give us a weight at the bottom and a height at the top to just show you where those limits of a 35-pound rear-facing seat put a kid in terms of a typical weight or height for their age. And then all of this conversation is going to be informed by my experiences working in the emergency department, taking care of kids. I know that a number of you have experiences professionally where you're on the scene, and I am going to be drawing on some crash scene photos that some of my colleagues obtained when I was still at Michigan, and then really kind of pick up on where that emergency department care is touching a patient and then following these patients through to their recovery. So I'm going to go through 7 cases and use these cases as an opportunity to illustrate examples of the benefits of using the different modes of restraint. The first case is from when I was in medical school and on the pediatric surgery rotation, and a toddler was brought into the ER from the crash scene. She was in a forward-facing convertible seat that was in the back of a minivan that crashed into a truck. She was found in the vehicle not breathing, and the first responders initiated CPR, and they got her pulse back. She was unconscious in the emergency department, and they were needing to give her breaths with rescue bag, and she wasn't giving us any response to our physical exam. She wasn't pulling back when we were putting in IVs, and she didn't have any signs of injury to the outside of her body. And this is the Zoom makes it a little bit hard because we can't do some kind of conversational pieces to this, but we'll keep kind of rolling through. The place that we need to be looking for injury in this child is in the neck. And with a lack of response and a lack of breathing, we worry about an injury to the high part of the spinal column. And the X-ray on the left side of the screen shows an example for our patient. And then on the right side of the screen, you see what a normal set of bones of the cervical spine would look like. And when we're looking at X-rays for children, we want to see that all of the little building blocks for their spinal column are lining up with parallel lines. But in the case of our patient, we look parallel there, but that other bone, the second vertebrae, is showing us a different angle. And that is indicative of a stretching injury that occurs when that big head proportion is pulled in the force of a crash and doesn't have any protection keeping it from pulling forward. And this young lady had an injury to that part of her spinal column and required going onto a ventilator with a tracheostomy, and was somebody who was wheelchair dependent. She was somebody that I continued to see back in the emergency department on rare occasions. Over the 15 years I was at University of Michigan, she was going to high school when I was last able to see her. And so she was able to have a very high functioning life given these devastating consequences of a crash that occurred when she was a toddler. Here's another illustration of that difference in body proportion and relative to the skeletons of a 16-month-old, a 6-year-old, and an adult. And you can just see there's so much head and so much weight there. The neck is relatively short and weak. And as we grow and mature, we are better able to protect our neck from those kinds of stretch injuries. I'm going to show here 2 videos. These might be familiar to many of you, but I really think it drills home the importance of rear facing. The first is going to show how a mannequin moves in a forward facing crash test when they're in the 5-point harness. And I'm going to show that one more time, just have everybody watch how much force and movement is going into the upper torso and the head, and how much movement of the arms and legs against the force of the crash you observe there. And that's that stretch force that resulted in a permanent spinal column injury for that girl. This next view, I think, is a really powerful video of how much that rear-facing seat is protective of the head and neck in a crash. So we have the same forces going into that crash, but the head and the neck end up being cushioned as the child rides down the crash with that rear-facing seat. So case 2 is a 12-month-old who was found in a rear-facing seat in the back of this vehicle that was overturned in a single car crash. She was dazed but awake, and she had a goose egg on her scalp. She was boarded and collared for transport and was sleepy when she got to the emergency department and very upset with exam. And when we went to touch her head, she had a big swollen area, but once we took her off the backboard, which was very upsetting to her given the location of her injury, she was able to move her neck around. And we know for kids that if they're experiencing pain, they're not going to be moving. And so that was a reassuring thing that she wasn't experiencing any neck injury from this crash. But when we looked with a CAT scan of her head, this is kind of a bread slice through the skull and brain. You can see here that part that we were able to see on the outside with a goose egg, and then underneath a fracture, a break in that bone of her skull. And this brings us to the common patterns of injury for children who are under 1 year and involved in crashes. And this is from a textbook that covers the epidemiology of child motor vehicle crash injuries and fatalities. And for this age group, that head and neck make up 80% of the injuries that we see. And when we look to our early toddlers, the 1 to 3-year-olds, we still see a significant number of children who have head injuries, but then start to pick up on some lower extremity injuries. And with the real world crash information that we have about the epidemiology of children who are involved in crashes, most of the children in this 1 to 3-year-old age range are in a forward-facing configuration for these data. So I think that explains that lower extremity injury, and it's not a result of a rear-facing seat with legs bunched up against the back of the vehicle seat. So now I want to just orient you to these slides with the growth curves. And what I've done here with the pink lines is given the typical weight limits for infant carriers and convertible seats at about 22 pounds, 35 pounds, and 40 pounds. And with that, I think it's a really powerful message to be able to give to families that even a really big 3-year-old is going to be expected to be under 40 pounds and can keep using that rear-facing convertible car seat beyond that second birthday. I think a lot of families that I've talked to have this perception about, you know, I've got a kid who's at the 90th percentile and I've got a big kid, and so they're too big for these kinds of seats. And being empowered with that knowledge that most even big 3-year-olds would still be in the weight limits for a rear-facing car seat might be helpful for you when you're educating families. With the little girl who had the head injury that was just shown, there was a brother in that vehicle as well. And he was a 3-year-old who was found dangling from the seatbelt as the car was upside down. And his booster seat was loose in the back. And it's not entirely clear to anyone if he was using that booster seat or if it was just a projectile. But with these rollover crashes, the crash forces are very complicated and really extreme. He was awake and crying and very scared and completely unwilling to be transported flat on his back. So the paramedics made the choice, which was the right thing at the time, to get him into the hospital, to let him be seated upright while he was transported by ambulance to us. When we saw him in the emergency department, one of the first things we noticed was this seatbelt sign. And this is one of the classic things that we look for in the hospital when we've got a child who was using a belt as their restraint. And this can be a little bit of a rug burn kind of look, or can be bruising. and it went right across the center of his belly, and is something that is a signal to us that we need to be looking at the belly organs as well as the spine. And for him, he had a very classic injury that we call a chance fracture. And when we're looking at the spine, again, we want all those building blocks to just line up straight, and we want all those building blocks to have a square configuration. But when we have a crash and it bends a spine over with a really violent force, the front part of that building block of the spinal column can get squashed by those forces and create this trapezoid look that we see here in the X-ray and the CAT scan that's shown. This seatbelt syndrome really has three pieces: the bruising on the belly, or that seatbelt sign, internal organ injury, and then the spine fracture together. And that's been described in the literature pretty extensively. Moving on to case 4. We had a 5-year-old who was 49 pounds. She was using a backless booster seat in the back seat and preferred putting her seatbelt under her arm. The family was involved in a front-end collision against a tree, and they came in with EMS and complaints of abdominal pain, but no evidence of head or neck injuries. Blood pressure was low despite us giving IV fluids, and that's a signal to us to be looking for internal bleeding and internal organ injury. And here for this patient, we had a little evidence that we were going to need to be doing some more investigation with a mark on the side of the hip. This is the pant line, and then the fold of the hip, and then up onto the belly. And when we look at the X-ray, we can see there's a little dark line here that's cracked across the pelvis bone. And the pelvis is a pretty big, strong bone. And so when we see that going on, we know we've got a lot of force involved in this crash. And so we took a little deeper look at things with a CAT scan. Just to orient everyone, this is another kind of slice of bread look through the body. These are the wings of the pelvis bone in the bright white, the spine bone along the back. The bladder is in the center here. And then we've got some dark area in the belly next to the bladder. And that's a sign to us of fluid that shouldn't be there, and an indication that there's an injury either to the bladder that's leaking urine there, or an injury that's causing bleeding. So this little one was taken to surgery, and they found an injury to the small intestines and repaired it, and they were able to be discharged home after 5 days in the hospital. So as we're thinking about that early school age population, the head injury remains a very common point of injury, and that's going to be a thread along all of these cases. But the chest and abdomen comes up as another leading cause of injury and point that we're looking for. With forward-facing seats with 5-point harnesses, we've got the advantage of the crash forces getting spread out across straps that are going to be positioned onto the bony parts of the skeleton. So over the collarbones, along the sternum, and over those strong hip bones. And that's what makes those forward-facing 5-point harness seats very protective against those kinds of injuries that you saw in the last 2 cases. Those cases had those injuries as a result of using an adult seatbelt, and that seatbelt riding up onto the belly of those kids where there aren't those bony parts to be able to protect against those crash forces. So as we're looking at typical weight limits for seats, 40 pounds, 50 pounds, some now even up to 65 pounds with a 5-point harness, we can see that 5-year-olds can very, very easily be well above the growth curve and still be under a 65-pound weight limit. We always have to take into account how tall a child is relative to the seat back, but I think that it can be a fair expectation for you to be setting with families that they can continue to use that forward-facing car seat until their kid's getting ready to go to kindergarten, and even longer. A 95th percentile 6.5-year-old would still be under 65 pounds. So just again, as you're starting to have those conversations with families who are going from rear facing to forward facing in seat checks, you can let them know that this is going to be something that can be with them for safe transport of their child up until kindergarten or longer. All right, moving on to case 5. We're moving up the age rank as we go here. We have an 8-year-old who was 60 pounds and 52 inches tall and was using a seatbelt during another front end collision. Because the law in Michigan, and they understand it to also be the law in Illinois, the parents thought they were old enough to be using a seatbelt, and they had kept their 4-year-old sibling still using a forward-facing seat with a 5-point harness. So these are that example of families who are really trying to do the right thing and using the law as a guide for what is best practice. This patient didn't remember the crash, but did say, "I know I got bent in half," and puts the shoulder belt behind their back because it rubs up against their neck and that's a bother. The thing that we were focused on taking care of in the emergency department was an injury to the left arm, and we could see that there was an obvious break going on there. But we also were cued into some belly pain, and there was just a little bit of bruising, nothing like that obvious seatbelt sign that we had talked about earlier. And this little one had a fracture through the bones in their forearm. And even though these look hard to look at, they end up healing really well with kids and pretty rapidly. We did an ultrasound test, which is one of the ways that we can look for internal organ injuries, and everything looked well there. The arm was casted and the blood pressure was stable overnight, and so the child was discharged home the following day. But then came back into the emergency department 4 days later because their belly pain had worsened. And with the crash happening just a few days earlier, this was a signal to us that we needed to look into what was going on. And we did that by doing a CAT scan, and this showed us injury to the duodenum, which is one piece of the small intestine, and that part of the small intestine had a large bruise that had swollen, kind of like a goose egg on your scalp, but swollen to the point that it was blocking part of the small intestine. That was something that needed to get treated with surgery and required several days in the hospital. And this child was able to make a full recovery. That arm was the fastest part of that recovery with 6 weeks in a cast. But this injury to the duodenum is one of the other things that we will see when there's a really forceful impact on the upper part of the abdomen. And we'll see that when we have kids who aren't wearing that adult seatbelt lap portion at the lowest position on their hips. And here you can see for our patient using stars where they fell on their growth curve. And then the shaded boxes are giving us the size parameters for a typical booster seat. So 80 to 120 pounds for a booster seat limit. And then this top line for the height bar is sitting at 57 inches. So even though this child was 8 and legally in a position to move into an adult seat belt, they still had plenty of room to continue to use that booster seat. And that could have potentially prevented the situation where they were trying to put that shoulder belt behind their back because it wouldn't be rubbing up against their neck, and it would have given that lat belt better engagement with their pelvis bones. All right, case 6. This is a 7-year-old who is 75 pounds and 54 inches tall. She was wearing a seatbelt and in the back seat when mom's car struck a tree. And mom really didn't see a reason for a booster seat because she had a big girl, and both big meaning to mom that she was an older child and also a little bit heftier than her peers in 2nd grade. She came into the emergency department with injuries to her face and to her trunk. And then the next photo isn't terribly gory, but I do want to give people a chance to divert their eyes for a second if a cut under the chin is something they'd rather not look at. So for this young lady, what we think happened is her shoulder belt was up high on her neck and against that chin line, and it caused a large 6-inch laceration to the chin line. And she also had a detachment of her lip as a result to her crash. And when we looked at her head with a CAT scan, we found that she had a number of broken teeth as a result of the crash and face and jaw fractures. So our best guess, in addition to the seatbelt being poorly positioned, is that she likely made contact with that front seat. And this set of images are showing us the added value of that top tether in a 5-point harness restraint to keeping a seat from crashing into the vehicle front seat in the situation of a crash. So this top still is an example of no top tether in use, and then that bottom still shows us when that top tether is in use, the child's arms are coming in contact with the front seat, but that face is not making contact, and that reduces the injuries involved. This is, again, just an example to orient you to this young lady. And mom was right. She is on the bigger side, but is still somebody who would have potentially benefited from a booster seat in terms of optimal positioning, and isn't somebody who was above any threshold by which a booster seat would recommend that they stop using it. Case 7 is the last case, and probably the one that is sort of the highest gravity and the reason why I'm most compelled to do this work. And it was a case I took care of when I was covering the emergency department on Christmas, and it was a terrible snowy day, and I don't know exactly what led the paramedics to need me to come out to the ambulance bay to verify this child had passed, but it might have been the holiday or the fact that the parents had needed to be taken to other hospitals in the area for their care from their injuries. They had found this child as a passenger in the back seat, and they weren't able to find a pulse, nor were they able to get a pulse back with CPR. So they had concluded that this was a fatal injury, but wanted my verification. So this is the only time I've ever been asked to come out to the ambulance bay and get into an ambulance to verify death, but I felt like that was the right thing to do given the request of the paramedics. And the child was under a white sheet on a gurney, and I lifted things up to just listen to the heart and check for a pulse, and found this bruise up by their belly button. And my best guess as to a cause of death that was so sudden from a crash is that with the forces of the seatbelt going against that child's abdomen, that it went so powerfully against their aorta, that major blood vessel that runs right up against their spine, that they had a bleed or an injury to that vessel, and they weren't able to keep enough blood pressure in to sustain life. So that gets us through our cases, and our common injuries for 8 to 12-year-olds still are up in that head region for the majority of them, but we see chest and abdomen and upper extremity injuries also involved, and a little bit more involvement of the face. And with the face and upper extremities, we think that that's a result of probably trying to brace yourself against a crash and then coming into contact with different pieces of the vehicle. And when we're thinking about booster seats, the relative to growth curves, the black lines show the minimum weights for the booster seats that are available on the market, down to a low of 30 pounds and a high of 50. And then the green lines are showing us the upper weight limits for booster seats. And you can see here from a weight standpoint, we're looking at a typical 11-year-old. And then if we take a look at things from a height standpoint, this line of arrows is at 57 inches, which is the point where we think an adult seatbelt's going to start to fit properly. And we don't even come in contact with the 95th percentile line until we're in the 10 to 11-year-old range. So I think messaging to families that a booster seat's going to be the way to go for kids through their elementary school career is what I try to emphasize. So the sort of shadow skeleton illustration shows why kids slouch when they're in a seatbelt without a booster seat, and trying to get that knee bent over the edge of a seat is a big problem, creates this huge amount of space behind their back and places that seatbelt up on their belly. And then this set of lines over the red and white outlined children, the red is a 6-year-old and the white outline is a 10-year-old, and you can see here that that shoulder belt path is going to go across the wrong position for most kids, and only 30% of shoulder belt fit is appropriate for a 6 to 8-year-old. You guys are well aware of what good and bad belt fit look like and what that seatbelt fit test is. And I want to just emphasize the areas that I think we have the greatest opportunity for improvement, and that's continuing to encourage families to go rear-facing beyond 1 year, to use forward-facing car seats beyond 3 years, and using booster seats beyond 7 years. And I don't know the legislative climate in Indiana, but you might have opportunities to think about how the law is crafted, and there might be more nuance to it than I'm finding on the internet, where it says all children under the age of 8 must be properly restrained in a car seat or booster seat according to the Child Restraint System manufacturer's instructions. I'm going to just spend a couple minutes on the other piece of work that I do with families in terms of trying to help them answer the question, is your child in the right car seat? And I'm going to share just a few quotes from focus groups that we conducted with families, because I think they really help illustrate where we've got opportunities to better align our communication across the different experts that families turn to. And the first example is from a mother of a 3-year-old who told us, I have a friend who's a pediatrician that's like, why is your child still rear facing? And I'm like, aren't you supposed to know this? I have an ER nurse aunt that was bugging me about it. There's peer pressure that I need to turn my kid around to face forward since he's older than 2. And this is calling out my own profession for not pushing as far as we can to keep kids safe. I know you guys do a great job of this. Here's another example where the pediatrician says, you have to stay rear facing until 2, but is just sort of like, good luck with that. It's not really realistic. Another thing we heard from parents is they're going to defer to laws over recommendations a lot of the time. So this father of a 2-year-old said, I went to the pediatrician and she had told him that he's forward facing, and she said, well, I recommend that he faces back. And I said, but that's not the law, is it? And she said no. And I don't think she was too happy about that, but she didn't push the issue. Here's another mother of 2, a 2 and a 3-year-old. When there's a suggestion versus a regulation for car seat safety, it changes how you think about it. For a regulation, you don't want to be caught not following it. You don't want to get a ticket. For a suggestion, if it fits with your experience, then you do it. And then when we're talking with families who've got these older children in booster seats and trying to navigate when to go to a seatbelt. For example, the front seat issue, it's not a law, but a recommendation. Another parent told me she couldn't sit until she was 12. So I checked it out and found out it's just a recommendation. You talk to people and then you verify. This is a mother of a 4-year-old who's really trying to think ahead and is looking for that truth in the law around what she should be doing. This is one of my favorite quotes, and just I think speaks to a lot of where families give up. My son's in 5th grade right now, and I want to say it came up around 3rd grade, and there was a very strong lobbying effort through most of 4th grade. And I finally said, all right, at the end of the school year for 4th grade, you can be done. And then he was. He's also big for his age too, so I felt like that sort of informed my decision. If he was a really scrawny kid, I probably would have pushed harder. So he's all right, I think. And there's this doubt that families have, but they're up against these very powerful arguers and lobbyers and future lawyers in their homes who know what their peers are doing. We did a survey of parents in 2 Michigan emergency departments who had children who are younger than 10 and asked them where they get their sources of information. And unfortunately, we, with the expertise around child passenger safety, aren't necessarily the ones that families are hearing from. And I think if we did these surveys more recently, that the internet would be probably up around 90% and family and friends would be high. But I don't think that we would have made a big change in doctor, nurse, and police officer, child passenger safety technician, firefighter. But this gives me hope. Anybody that has children in a car seat can always get more information because, like you said, the laws change, studies change. With that is still so confusing because so many people, I'm on Facebook and moms are always saying this and discussing that. And you're like, you do that, you're a bad mom. So I think we've got a place to be engaging with families, informing them, and being a source of accurate, trusted information. One of the other things I just want to take 1 second to kind of mention with the work that I'm doing to try to address some racial disparities that we see in child passenger safety is this idea of the 3 E's of injury prevention, engineering, enforcement, and education, and bringing in this 4th E of equity and trying to find ways that we're reaching families who might have a different set of circumstances, a different language, a different culture, and being sure that we're trying to meet them in ways that we're communicating so they can understand and buy into the rationale for why it's safer to continue to be using restraints as long as possible. And with that, all of the things that I've been able to accomplish in my career are to a credit of a long list of folks shown here. And I'd be happy to take questions. I appreciate everybody sticking with me through this talk.
Thank you so much, Dr. Macy. I learned so much around orienting to those growth charts and really being able to utilize that data to teach and talk with families. So thank you so much for that. We do have a few questions from the chat box right now. And so I'll go ahead. Alicia said, what's the best for an 8.5-year-old that's 4 feet 3 inches tall and weighs 110 pounds? Booster or just a seatbelt?
So I think that my understanding of the booster seat is that weight limits are less important for them than they are for the 5-point harnesses. And really the weight of that child is going to be protected by the seatbelt, which they can use as long as possible. And that booster seat, if they're not able to get good belt fit with the belt going across their clavicle and staying there for the entire trip and staying low on their hips, if they can get a booster seat that is wide enough to accommodate their size or low profile enough to accommodate their size, that would probably be a benefit to them.
Okay, thank you. And then we have another question from Paul. Paul said, what is the recommendation with booster seats that have the removable backs? Does it make a difference?
So with those removable backs on the booster seats, the main difference that we can realize with those boosters is a little bit more control over where that seatbelt lies on the child's neck, or hopefully bringing it down over their clavicle. And as you can kind of see in this poor example of my daughter as we pulled into our garage years and years ago, you know, if we had a high back booster there and she was sleeping, she wouldn't be up against her brother's 5-point harness. She would have that headrest, and the positioning for that shoulder belt would be more optimal. The back itself doesn't do anything in terms of changing the safety of the seat as long as the shoulder belt can be in a good position. Again, that main function of a booster seat is making sure that the belt for both the lap and the shoulder portions is hitting on the bony parts and keeping them in that position if they're ever involved in a crash.
Okay, thank you. Also, thanks you. So does Alicia. Does anyone else have any questions? You can unmute yourself. We have a couple of minutes left if you'd like to ask your question, or you can also type it in the chat. All right, well, we will keep that chat alive if anybody wants to add anything. Okay, we might have one or two more. Sorry about that.
So I can see from Tyler, any recommendations for vehicles with lap-only belts? And I think that my recommendation for that situation is to really use a 5-point harness with highest weight limit you can get as long as possible. That lap belt is going to put that child's belly at significant risk, and a 5-point harness will be very effective in moderating that risk, and you can use that lap belt to do the installation for the car seat.
And then on behalf of Safe Kids Indiana, the Automotive Safety Program at the IU School of Medicine, and our funder, the Indiana Criminal Justice Institute, we would like to thank Dr. Macy and everyone for attending today.